Our next speaker of the day is Associate Professor Peter Gonski. He has been a consultant geriatrician for 28 years, is the current lead of South Care, Aged and Extended Care at Sutherland Hospital and Community. He's also the clinical stream director of the Aged and Rehabilitation Clinical Stream at Southeastern LHD, and conjoint Associate Professor, Faculty of Medicine at UNSW. Professor Gonski is going to talk about frailty and in part about falls and fractures to help us think about what interventions might help our patients. Here is Peter Gonski with the F words that older people hate. Please welcome them.
So I changed the topic from frailty to this. It did begin the F words that older people hated, but I was always taught by my father that you shouldn't use the word hate, so I changed to do not like. Now the other words that geriatricians use a lot are the D words: delirium, dementia, and depression. But we've heard a bit about dementia today, so I'm going to talk about the F words. And the three F words that we talk about are falls, fractures, and frailty. And really, these are disastrous as one gets older. So what I'm going to do is talk quite a bit about frailty, and then I do want to talk a little bit about falls and fractures and the assessment of those, because firstly, we are holistic people, and that we have to think of the patient as whole, and falls and fractures go very much hand in hand as a result of frailty. And the other thing is, I have an audience here, and I do want to pass on a few things that are very important to us, because in aged care, where we work in aged care, we need full integration with primary care and vice versa. And it's really important for us to talk to you about some of the things we're doing in these areas so that we can get good integration across the patients that we all look after. Now, there's a very big question about what frailty is. And there are many definitions, and some of them are used in research, and some of them are used in clinical practice. And some look at function only, some look at cognition and function. So it's all a big whirlwind, and no one actually knows what the answer is to this question. But one thing that everyone's pretty sure about is that there is vulnerability, and that is that a frail person, if anything goes slightly wrong, they're going to do pretty badly, unless they're managed pretty well. So vulnerability is the key word in frailty. So it doesn't mean just cognitive decline, it certainly means falls and low trauma fractures or minimal trauma fractures. People deteriorate in their mobility, they often develop urinary incontinence, and as you all know, urinary incontinence is often not spoken about because people accept that it's normality. And I never forget a patient who came into hospital for something, I think it was pneumonia, and she once told me that she'd been incontinent for 25 years. And I said, well, why haven't you had anything done about it? And she said, well, it's normal to be incontinent after you've had a couple of children. And I gave her a little bit of an anticholinergic, which I know is a naughty with some people, but I gave her a bit of anticholinergic, got rid of her incontinence within about 48 hours. Not to say that's the only treatment, but, you know, we don't talk about these things, and yet they are there, and they're very important, and they certainly get worse as you get frail. Now, people who are getting older, they get more frail, and they also accumulate multiple medical problems, and then they accumulate multiple medications, and all adds up to an even more frail person. And we definitely know that more medications you're on, more polypharmacy, more side effects. I won't talk about any more about that because I know that's going to be covered later. Now, frailty increases with age, although you can be much younger when you are frail, but certainly it increases with age. It increases with more medical problems, more medications. It's very poorly diagnosed because people do not understand it. And this is not just here or in Australia, or it's in the world. People just do not understand it. We know that it has poor outcomes, particularly when people get acutely unwell, and they particularly even more so if they're admitted to hospital and they get all those complications of hospital. And delirium, falls, fractures, medication problems, and all those sort of things. Now, it's very time specific. So someone could be sort of mildly frail and then they get very ill and they become severely frail, but then they may get better again. And I've had a number of patients who we've rehabilitated from basically complete bedbound to independent with possibly a walking stick. And that's not uncommon in what we do, particularly if they were only mildly or not frail before the specific medical problem that they unfortunately get. So it is reversible, but often it's not. And the most important thing is it requires a full assessment. And a full assessment in aged care is not just medical, which is what we often do, but it's to look at the medical problems, all the medications. It's to look at the social interactions and the environment the person's in, and that's not just for dementia sufferers, but for everybody. It's to look at how they function at home, and that's not only gait, but it's also their activities of daily living, and also their cognition. And we need to look at all of that. And if you don't do a full assessment of these people, you really don't determine whether they're frail or not. So people who become frail require more care at home. They subsequently often need aged care facilities. They certainly need more community intervention if they stay at home. They definitely have longer hospital length of stays. They're vulnerable to anything that happens, even a minimal medication change or even a flu vax or something like that, they can be quite vulnerable to. And there's no doubt that there's an increased mortality, and it's an earlier mortality if they're frail. So the big point is to try and define frailty in a patient. Are they frail, and how are we going to prevent it from deteriorating? Because if you can make them as fit as possible before their acute illness, then they're going to do much better. So here's a little question for you. Is this fellow frail? He transfers with difficulty, he has poor gait, he falls a lot, he actually needs help with his feeding, he's incontinent of urine and he's incontinent of feces. Would that add up to a definition of frailty? And the answer to this is yes, maybe, but you need all the facts. And the fact with this one is that the person is only a baby and is probably a little bit frail compared to an older person, but not frail compared to a very old person. And I think you do need all the facts, and that's why I always put up this slide, a full comprehensive assessment. So I work in the Sutherland Shire, which is in the south of Sydney, and we have a lot of older people. In fact, we've probably got one of the highest percentages of people over 70. So I took our numbers, but in fact the percentages, maybe not the numbers, but the percentages are very common if you have older people living in any community. So if you take 250 to 300,000 population, about 10% will be over the age of 70, which is about 30,000 residents, and about 10% of those will be considered frail, and of those, a fifth of them will be moderately frail, and 60% of those, of the frail ones, will be mildly frail, and the rest will be quite significantly frail. So we are dealing with quite a number of people, and this excludes people who are already in aged care facilities, because one has to consider that people in aged care facilities are already frail. And that's one thing that is very much not considered, that when someone goes into an aged care facility, they are becoming frail, whether it's cognitively, physically, or both. And in fact, they're down there on the trajectory of downward. And the interesting thing about it, and I won't mention too much about advanced care directives as we've just spoken about it, but I'm very involved in it, that people don't realise that once people hit aged care facilities, they are on the downward trajectory, and that's where advanced care directives should really be discussed. And that these people are on the palliative pathway too, many of them. If we see the new term of palliative care being sort of comfort care rather than terminal care, we see that these people need to be considered in some type of palliative mode. Maybe not end of life like they're going to die next week, but certainly a palliative setting. So we exclude aged care facilities, we have those numbers, and we have a significant number of frail people around. Now it's interesting that in this journal article it says that there are actually, they've looked at a lot of articles and they've found 35 frailty tools, which usually means that if you've got anything of that number of anything, it means that no one knows anything. There are 35 tools in the literature on frailty, so I'm not going to tell you which one to use, but the common ones most often used in particularly the clinical settings is the Rockwood one, which I think in Sydney has a very unfortunate name because of Rockwood. But actually, interestingly enough, Dr. Rockwood is actually in Sydney this week and talking at North Shore Hospital on Monday. And look, this one appeals particularly to surgeons because it's pictures, and all they have to do is look at the pictures and decide whether they're going to operate or not. Now, clearly this person is very, very active and not frail, and clearly this person is about to die. And then everyone fits in between. But if you've got anywhere between basically anything below 3, here and here, it means you are on the frailty spectrum. And that is helpful. And it is also helpful to know that if you have an operation, particularly, for example, a fractured hip, there is a very, very high likelihood that you're going to move at least down one of those parts of the spectrum. So if you are here, you're going to, if you go in with a stick, you're going to go out with a frame, and when you're out with the frame, you're going to probably require a wheelchair at some stage. So this is actually a good way to determine who surgeons should operate on. The problem is it does not include cognition at all. So we know that a lot of demented people are like this, but in fact, they are very vulnerable to deterioration if something goes wrong, particularly with delirium and subsequent deterioration in their dementia. The Edmonton one, which is used a little bit less commonly, it's a little bit more complex because it's got words rather than pictures, but it includes cognition, which can be quite useful. So there are lots. I personally feel that if you do a comprehensive assessment of the patient, you don't need tools. Now, the tools that we tend to use, particularly in research, are of cognition, strength, and balance in frailty. And in cognition, people tend to use the mini-mentals, the Falstein particularly, and the MOCA, which is the Montreal Cognitive Assessment. Now, of interest for those of you who use the MOCA, which is, I think it's certainly more complex. I don't think I'd score well on it, but it is complex. And people using it a lot now because it basically tests frontal lobe dysfunction much better than certainly the mini-mental, which doesn't test frontal lobe dysfunction at all. So people are using the MOCA. There are major problems with the MOCA. Firstly, it is complex, and if people are sick, they really can't even think about some of the questions. And the other thing is that the MOCA people have decided, the Montreal people, that they're going to only allow people to use it if they've been trained, and to be trained you have to pay. And also, you probably don't know that the Falstein MMSE, you're meant to pay them $1 every time you use it, which would mean that I would be in jail by now because I would have had to try and find the money or steal the money because I've done so many MMSEs in my life. So I may change the questions and call it the Gonski MMSE, and then I don't have a problem. But they're the common ones, but the mini-mental particularly is not a good, it's useful in Alzheimer's disease sometimes, it's not useful in the other dementias, it's certainly not useful in delirium, and therefore these tools are helpful, but they really should not be used as diagnostic outcomes. Now, strength. So I brought a grip strength monitor, which we use for interest. And mainly last night I tested myself to make sure I wasn't too frail. So basically you turn it on and then you do that and you test your grip, and there's a little blurb that comes with it that tells you whether you're frail or not by what pressure you pulled. So that can be quite useful in measuring hand strength, but of course if you just hold someone's hand and tell them to grip, well, that might be enough. The standing balance test, which is to stand, I was going to get everyone to stand up for 20 seconds and see whether they can stand on one foot, but then I thought I might be responsible for a few falls, so we won't do that. But you have to stand on each foot individually for 20 seconds. Don't stand on both, bring them both up at the same time for 20 seconds. That doesn't work. The 6-minute walk can be quite useful to look at exercise tolerance, and that should be the time up and go, which you should be able to basically sit in a chair, stand up, walk 3 meters, and walk back to the chair and sit down again in about 10 to 11 seconds. Now that also alters with age, and if you look at the actual article that wrote it up for the first time, it'll actually give you an age change, so that if you're between 60 and 70, you take a little bit longer, a little bit less long than if you're 80 to 90. But it's about 10 to 11 seconds you should be doing that. So you can all go home and practice all those, so that when I assess you, you do very well and I don't call you frail. But there's some of the tests that we use. They can be quite useful in clinical practice. They're very simple tests, and we also use them in research as well. Now, the evidence is that if you screen a general population for frailty, you don't do well. But if you screen patients who sort of are starting to go down the deteriorating spectrum, then you will actually do very well for them. Now, the important thing is the assessment, which I've already mentioned, but the most important thing after that is obviously to intervene. So it's all very well doing a whole lot of screening, but if you're not going to do anything with it, it's a waste of time. So I know that you have the over 75 screening, which I think is a very good tool, and we in fact use it in research when we want to integrate aged care and general practice. So it is very good, but the problem with it is if you're not going to look at it and say, well, what are the deficits? What are we going to do about those deficits? Then it's a bit of a waste of time. I know it's quite good to have it done. It's good a little bit reasonable financially from a Medicare point of view, but from the patient point of view, you have to intervene. So you have to pick your patients as deteriorating, then you have to assess them, then you have to intervene. And if you do all that, there is good evidence that you improve quality of life, you reduce functional decline, you reduce cognitive decline, and there was discussion by Alan about the possibility of exercise, which is very important both for the brain and the body, and you reduce hospital admissions. And people who work in hospitals always talk about reducing hospital admissions, which is very good for the hospital, but it's also incredibly good for the patient, because try and keep people out of hospital, and if they do come to hospital, they should minimise their stay in hospital, because the complications of a hospital are drastic to older people, particularly frail ones. So we've set up a frailty model in our district, and we're hoping in the future to pass that on to other districts beyond Sutherland to St George and to the eastern suburbs as well, and further through Sydney. Now, it is based on what we call the integrated skin cancer model, which we also put together with funding from the government, where we brought along GPs and we taught them how to diagnose and treat skin cancer. And working with them was a dermatologist, a vascular surgeon, a plastic surgeon. They were all working together. So everyone was sort of working together as an integrated model. So we've taken that model, we set up that model in the Shire, and it's been moved to other places, to the north of Sydney and down to Wollongong. Now we're using the same model for frailty. So we're taking in GPs and we're training them up in basically assessments and what we do with these patients, so that they can take them back to their practices and look after these patients who are frail and getting frail. Now that's really important, because certainly aged care specialists cannot look after the full spectrum of frailty, and these patients are bread and butter for a lot of general practices. So that's why we're doing this. So what we do with these patients is they're referred. We assess them, we give them a management plan, and we follow them up, as with a lot of research projects. We do a full comprehensive geriatric assessment, as previously mentioned. We do the over 75 assessment if they haven't been done by the general practitioner. We use a frailty index. We do any investigations, we do medication reviews. We also look at eyes, because eyes are a big one for particularly falls and fractures. And if someone hasn't had an eye assessment in the last 6 to 12 months, we get them to have one, either with their previous ophthalmologist, optometrist, or one of ours. That's a really important aspect. We do gait and mobility assessments, and we also do quite a lot of exercise, so we send them to exercise classes. And the other thing we do is we actually put them into My Aged Care. So the My Aged Care, you all know about the My Aged Care. People don't want to talk about it because it's so hard sometimes to access. So my exercise program people actually work for My Aged Care. They actually assess us for My Aged Care. So they help these patients who go into this research project to actually access My Aged Care. And they happen to be assessors for My Aged Care, so they can take them on to assess them for any community services and socialisation and things like that. So basically this study looks at improvement in frailty scores, improvement in balance, in exercise, in quality of life, in cognition possibly. Now the concept of how many days does someone stay in hospital is being reversed, and we now see it as a positive thing. We talk about how many days at home. So that is, how many days can we increase patients being at home, and that means how many days can we keep them away from a hospital, and how many days can we keep them at home rather than them going into an aged care facility. These are some of the things we like to look at. Eye assessments I mentioned, assessment for My Aged Care. We look at hospitalisation per year, time to admission to an aged care facility, and we also very strong on client feedback. How do they feel about what we're doing for them? Is it helpful to them? That sort of thing. So that's what we're doing. And why is this different from anyone else around? We do know that comprehensive assessment and exercise have been well proven to improve frailty in patients or frailty outcomes, but the two things that our particular study is looking at is GP training and the outcomes of that, and also having rapid referral to My Aged Care and doing something about it and having the assessments done quickly, because the big thing that everyone's talking about and the Royal Commission's talking about is how long it takes to get an assessment, and then how long it subsequently takes to get any services going. We do it just across the road from our hospital. It's a community-based study. It's funded through Medicare because we have a GP and a specialist, myself, involved in that. But there are a number of funding partners, including the PHN, this PHN and the LHD. So I want to now talk about the other F words, and that's falls and fractures. Falls are the commonest cause of acute deterioration in an older person. It's also the commonest cause of older people coming to emergency departments. It's also the commonest adverse event in hospitals. We know that people don't get fully investigated for their falls. They get fixed up for the actual outcome of the fall, that is the fracture or the non-fracture. But people don't look into the cause of the fracture. And we've looked into why do people get actually fall. And if you look at it, 50% are medical causes, some of which are chronic, such as Parkinson's, strokes, that sort of thing. And about half of them, of that 50%, are acute anemia, sepsis, that sort of thing. And the other half are mechanical. They trip over something, or they're pulling a curtain down or something like that. So my outcome of falls is to whip falls. Why? Injury, prevention. So why do people fall? I for injury, and that's not always determined unless you do further x-rays. We found that 10% of fractures are missed on normal x-rays because of osteoporosis mainly, and we have to further scan them with bone scan, CT scan or MRI. So why do the people fall? I for injury, P for prevention of osteoporosis, and P for prevention of further falls, which usually involves some type of functional assessment. So to summarise falls very quickly, if you think of this an acronym, DAME, if you think of drugs and alcohol, age-related physiological changes such as slowing down, slowing gait, cognition, those sorts of things, acute medical problems, I mentioned sepsis, anemia, those sorts of things, and the underlying environment, which is all those mats on the floor, you go into people's places, there's stuff everywhere. To test it, again, the timed up and go test can be quite useful, and the single leg stance test, both of which I've described. Now, you need to do a whole lot of things when you find that someone's falling. It needs to be a team approach. I've mentioned vision. An exercise program we'll talk about, but it is important. Environmental assessment is important, so looking at people's homes and why they're falling over things. And it's not hard. You walk into these people's homes, you can hardly get through the front door, or the dog comes running at you, or something like that. Falls clinics. I'm not a great fan of falls clinics if you're doing a full assessment. If a GP is doing full assessment, or someone related, general geriatrician is doing a full assessment, I'm not the greatest fan on clinics, but some people find them useful. Podiatry is important because of the feet keep us up and walk us, and that's really important. And don't forget the medication reviews. So it is a coordinating prevention of falls. Now let's just get on to fractures now, because I have to go fairly quickly. This is the fracture continuum, and the worst prognosis is this hip fracture. You don't want to get to hip fractures. And the best prognosis, if you have to, is a wrist fracture. And I can tell you that shoulder fractures are pretty bad too, because basically we don't tend to operate on them. And in fact, hip fractures can often do better than shoulder fractures, because people who have shoulder fractures basically have to keep them in a sling for 6 weeks. The first 3 weeks not doing anything with them, and the last 3 weeks they can start doing a little bit of pendulum exercises. So they do particularly badly. At least with hip fractures we fix them, and then they can get up hopefully the next day and off they go, but they don't do well generally. And the reason they don't do well is not because the surgeons aren't good, because a lot of them are very good at these and very slick. What the problem is mainly is that these people are frail, and now they've got a hip fracture, which is not the problem. The problem is their frailty. That's why their outcomes are so bad. So when we look at fracture prevention, we need to try and basically look at why people are falling and do they have osteoporosis, and if we can treat both of those, then maybe they won't have their fracture. If they have a fracture, we need to stop their next fracture, and the only way to do that is assess the falls and then assess for osteoporosis and treat both of those, falls and osteoporosis. Of women suffering a hip fracture, 50% will go out with a walking aid, even if they didn't have one before. 18% will end up in long-term care, even if they weren't before. And 25% will die within a year. So it is a shocking outcome generally, even if they're treated as best as they can. And the reason is because they have an underlying frailty. So this leads me to my last part of my talk, and that is the minimal trauma fractures, the people who fall over and fracture. And what happens with these people is they often get treated for their fracture but nothing else. So the falls reason is not looked at, their general frailty is not looked at, their nutrition is not looked at, they don't often go into significant exercise programs, and it is a missed opportunity. And furthermore, they're not treated for osteoporosis, and therefore next time they fall they will have another fracture. Whereas at least if they have one fracture and we treat them for their falls and their fracture, we will reduce the chance, and significantly we will reduce the chance of further fractures. 75 to 80% of patients with a minimal trauma fracture, agility fracture, that's someone who has a minimal trauma and they fall over and they break, have not been investigated or treated for osteoporosis. Basically, the outcome of investigation of these people is very poor, and that because of that they continue to have fractures. Now, many of these people don't even know they've had fractures, because vertebral fractures can be basically asymptomatic. I mean, vertebral fractures can be so painful, but they can also be absolutely asymptomatic. And if they're not picked up and treated, then that's their first fracture. Their next fracture will be more significant, such as a terrible vertebral fracture or a hip fracture or something like that. So 46.5% at first fracture, refracture within 24 months if they're not looked at from a falls and osteoporosis point of view. A third of our fractures have fractured before, and we could have avoided that if we treated them properly. Refracture patients have an average 3 weeks in hospital, and 17%, a shocking 17%, die within a month. So the outcomes are horrible, and if you don't like it for the patient point of view, we could be saving about $140 million a year just in doing this treatment, basically looking at these patients properly. Now, I might just tell you that bone density is not great at picking up these patients who fracture. And you'll see that it's clear that these are the people with very bad bone density. Yes, they have a high incidence of fractures when they fall, but the highest level of fractures are actually in the osteopenic range. And the reason is because there are more people who are osteopenic than there are osteoporotic. So if you look at the numbers, more people fall, you've got this number of fallers, more osteopenic, there are going to be more fractures in that level. So although bone density is important, it's only one aspect of the whole thing, because you have to investigate and stop people falling, which can be quite difficult. Now, the risk factors for actual fractures are, firstly, females more than males, age, which is not surprising, a prior fracture is a high risk factor, a very high risk factor, and risk of falls. So if we can't do much about this one, we can't do much about this one, but we can do a lot about that one, and we can certainly do a lot of that one. And the comment at the bottom really is that if you have two individuals with one with worsening bone density, then obviously that one's more likely to fracture, but certainly the other one who doesn't have worsening bone density will also fracture. So to assess fractures and treat fractures, it's very similar to frailty and falls, and that is take a good history, do a full examination, investigations, look at the medications as well, take the blood pressures lying and standing or sitting and standing. Think about why people are falling and therefore subsequently fracturing. What is the injury? Treat the injury of the fracture. Prevent the falls and prevent osteoporosis. So the same as falls, basically. The treatment is, firstly, you do need to educate the patient on why they're falling, how they should stop falling. Once they're falling, how do they get off the floor? That's very important. Diet is incredibly important, and nutrition. Exercise, which I'll spend a minute on. Calcium, vitamin D, really, really important for bone and muscle strength. And it's important because people do reduce their calcium intake when they're older, particularly if they have concerns about the amount of calcium they're taking, but also they change their milk intake and all that sort of thing because the cardiologists tell them they should reduce their fat intake and that sort of thing. Vitamin D levels are very important, and I would suggest that they be done at least once a year, if not twice a year, on patients. And we should be considering all patients to have osteoporotic treatment if they've had a previous fracture. Now, you probably can't see this at the back, but it's basically all the causes, the medical causes of bone loss and therefore osteoporosis, and that'll be in the slides, so you can go through them. But they include endocrine, nutrition, medications, genetic disorders, which are rare in this age group, obviously, and others. Now, I just might remind you that we talk about nutrition, we talk about medications, we talk about exercise, all related to help from our allied health staff. So we need pharmacists, and we need dietitians, and we need physiotherapists, and we need exercise physiologists, and we need occupational therapists, etc., in our full assessment of frailty, falls, and fractures. Very, very important. Don't forget lifestyle. Sometimes we can't stop frailty because people are deteriorating, such as in Parkinson's, etc. But there are a few things they can do. We've talked about exercise. You can review the medication. Diet's really important. Smoking and alcohol consumption. The alcohol consumption in older people is massive. You won't realise it, but it is. We've talked about exercise. Secondary hyperparathyroidism, which is usually related to low calcium, low vitamin D levels, and the falls risk. So there's a lot patients can do, but we have to help them. Now let's just talk about physical exercise. It's not just about walking 20 minutes a day. That's what people sort of have been told, and that's pretty good. Well, it's better than nothing. And getting out in the sun is a good thing from the vitamin D point of view. And if you sort of talk to a few people along the way, then that's a bit of socialisation, so that's all good. So that walking and exercise is quite good, but really we've got to get those muscles moving, okay? And we do suggest, if they can, is to do a little bit of this. There's lots of exercise programs that are around, and we should tailor it for the patient, because clearly people with walking frames can do very much less than people on sticks or no aids at all. But they are important, and that's where exercise physiologists are very useful to try and give that individual an exercise program. We do believe in not just walking, but actually improving the strength of muscles, and that's what these are about. Basically, weight-bearing exercises, high-intensity resistance. You have to take into account, obviously, all the medical problems. So we need to increase bone mass and muscle mass, so muscle strength. Individualise, I mentioned, and we should progressively increase. That's the way to do it. So start slow and low, just with medication, and build them up. And they will find that there is improvement, and therefore their chance of falling will reduce. Calcium and vitamin D and anti-resorptive treatment, so important. Simple tests for the calcium, vitamin D. Don't give too much vitamin D, because there is some evidence that over about 110, level of 110, they can actually get some weakness in their muscles. So we don't want too much, but we do want their levels to be up. So it is important. And the osteoporotic treatment is also important for anyone who falls and fractures, but particularly people with low bone density. So what we want to try and do, these patients have osteoporosis or osteopenia looking like that, and we want to make them normal bone again, and the best way is to give them exercise, calcium, vitamin D, and osteoporotic treatment. So there's lots of osteoporotic treatment. I'm not going to tell you which ones to use. We do tend to use denosumab the most, because it's easy to give 6 monthly, as long as it's given on time. It must not be given more than 2 weeks beyond when it should be, because you lose the full effect. So they needs to be recalled within every 6 months. We like it because it's a bit better with renal dysfunction. It's very easy to give. Basically, they don't have to take it every day, all that sort of thing. But some people are still on bisphosphonates, and that's fine if they're doing well. People talk about drug holidays. That's still not really determined unless someone has sort of some side effects from it. Which some people do get in the teeth or bones or whatever. So you can continue the bisphosphonates. We tend to use denosumab. They would be the two big groups that are still being used for osteoporotic treatment. In selecting treatment, it really has to be determined by the patient and their comorbidities, and also what they want. If they want to take treatment every day, that's fine. If they want to take it once a month, then that's fine too. If that, you give them a bisphosphonate once a month orally. If they're happy to come in every 6 months for an injection, and it's a very simple injection, then that's fine too. So you really just have to decide on the patient in deciding. As far as I'm concerned, as long as they're offered treatment, that's the most important thing. Teriparatide, a very, very good drug. I think it's the best osteoporotic treatment we've got. The problem is it's only $18,000 for 18 months, unless you fulfill the criteria, which include a bone density of worse than -3, and that you've been on bisphosphonates or denosumab for 12 months, and also that you have a second fracture. So some people fit in with that PBS criteria and get very cheap teriparatide, which is Forteo, by the way. Okay, so the real issue in frailty, falls and fractures is identifying the patient. I think that I can pick a frail patient from seeing them just walking down the corridor. But what I do about it is more important. I do a comprehensive assessment. I give them some ways of improving their outcomes, and that is medication changes, checking their blood pressures and making sure they're on the right antihypertensives. I give them an exercise program or refer them to someone who will do an exercise program, and I check all their other problems, talk about their functional problems, their social problems, etc. So it's really important to identify that patient, assess them, and then give them a management plan, because if you don't do a management plan, they're not going to get better. and they're not going to do well. So finally, I just want to talk about fraction liaison services, which is something we've also started in each hospital in Sydney. The government's given us money to do this, and these are for patients who are missed after they've had the first fracture. So basically we're identifying patients, particularly who come to ED and get sent home because they've got a, say, fractured wrist, they put in a plaster, they're sent home. And they're basically their falls and their osteoporotic assessments are not done. They're certainly not done in ED, and they may not be done in primary care. If they are, then that's fine. They don't need to come to a fracture liaison service. But what we've done is we have identified patients who've come to ED who are sent home, because the ones who are admitted, if they come in under, for example, aged care service, then they will be looked at from the falls and the fracture point of view. But if they're sent home, they won't be, and basically they're put in a plaster and the plaster comes off in 6 weeks, and no one often thinks about this. So we basically want to identify those patients, bring them into a clinic and look at exactly what I've talked about today. So that's what we're doing. But if you do that, if you see your patient and you do all the things we've talked about today, then they don't need to be seen in clinics, they don't need to be seen in a liaison service. But as long as those specific points that I've mentioned have been covered, then the patient will do as well as they can do. There are lots of fracture liaison services. We tend to do it through a nurse and doctor-led service. So I'll finish off there. If there's any questions on falls, fractures and frailty, or any of the other words that we could use with aged care, happy to answer them.
Could you comment on a couple of things? I mean, the frailty itself, even if someone completes the test and get a low score, they do better than someone who can't complete the test at all. And the other thing that I want just to comment about hip guards and their effectiveness, and people that are on bisphosphonate for a long time, they can get fracture without falls, without trauma, transverse fracture before. Is there a time frame on that?
Yeah. So the longer they're on it, or if they've had intravenous bisphosphonates, there's more likelihood of those fractures. And those fractures are very unusual fractures. They tend to be mid-shaft fractures, particularly in the lower limbs. And they're often not, as you say, there might be absolutely minimal trauma or no trauma. And look, they are a side effect of bisphosphonates. And they will appear they should be appearing around 5 to 7 years after treatment, but we've seen them much earlier than that. But as I say, bisphosphonates were used a lot previously, but actually they're not being used as much now. But at the same time, people are questioning, well, should they have this drug holiday? And as you probably know, bisphosphonates do not allow for normal architecture in the bone. It's very abnormal bone architecture. There's stronger bones, but it's very abnormal bone architecture, and that's why some of them refracture in a very, very unusual way. So should they have medication holidays, drug holidays? Look, I've been to lots and lots of talks on this, and some people will say yes and some people will say no. Certainly if they've had side effects, definitely. But I still feel that if someone's gone 5 to 7 years on osteoporotic treatment, such as bisphosphonates, and they haven't fallen and fractured, they're probably doing pretty well. You might want to do a bone density, see where they're at, but they're doing pretty well, and maybe they should just be left alone, continue on. Because there are definitely a large number of people who do very well on these drugs and they don't refracture for a long time.
Hip guard.
Sorry?
Talk about hip guards.
Oh, yes. Look, I think that's also a difficult one. Definitely there's been some studies that have shown that they're useless, and other studies that have shown that they are actually quite helpful, particularly in aged care facilities. I think where the literature is at the moment is that they probably are quite useful, but they actually have to be worn in the right place. And that's a stupid comment, but in fact, people put them in the wrong places, and they don't actually guard the hip particularly well. But I would say that in people who are falling a lot, that they probably would be useful. Yeah.
Could increasing calcium intake alone
help the osteoporotic?
You need adequate calcium intake. So you don't sort of say, well, keep on taking more and more and more. You need, now that's about 1,300 milligrams a day. So you need to actually try and work out how much people are taking. Now, some people take a lot of calcium. They drink a lot of milk or a lot of ice cream or whatever it is, and they have adequate, they do not need supplements. Whereas others, you can really tell that they are very low on calcium and their intake, and they need to increase it, and that's where we often give medication supplements. Vitamin D is a very different issue because, people who are in the sun, you think they're going to be fine, but you do find some people who actually are in the sun a bit don't have good levels, and people who never go out in the sun have very good levels. So I just think measuring it is really important, but the most important thing is that you get them above, in most labs, around above 60. I mean, it'll say 50 in the sort of the lower level in the report, but we really like to keep them at least between 60 and 100. And they do need vitamin D supplements, a lot of people, but you need both of those. And particularly if you put them on treatment, particularly denosumab, but also others, but particularly denosumab, if you don't give them both with denosumab, they will become hypocalcemic, and that is quite significant. So one has to be careful there.
Vitamin K now. Once it used to be thought vitamin K was important in treating osteoporosis.
Vitamin K, I mean, as you know, is it's used in coagulation, but it's not really important in osteoporosis at all. We'll stick with calcium and vitamin D. I mean, look, Alan mentioned this morning about ginkgo and all other things for the brain. There is no evidence that any of that stuff, I shouldn't call it stuff, any of that treatment is of much benefit. We used to use a lot of vitamin E when I started this. We used to give people masses of vitamin E because that was in. Ginkgo is in. There's no evidence for any of that, but there is a lot of evidence for calcium and vitamin D in bone and muscle strength.
And magnesium?
Sorry? Magnesium is an interesting one. It's actually quite a useful thing to have. Certainly for muscle cramps, it helps a lot. No one knows why, but it obviously changes the calcium-magnesium interchange in the muscles. So it is helpful. Again, we don't tend to give magnesium very much unless they have cramps. The cardiologists use it quite a lot in the acute setting when they find out someone's got low magnesium, mainly because they don't want arrhythmias. But generally, magnesium is not something that's sort of thought about as much.
Thank you, Professor.
Okay.
We'll hold questions.